patient doesn't see. It is the typical treatment that you are going to suggest to your patient. And in English it is called peanut shape, because in here you can have a reabsorption of subcutis upper, usually you are upper to the temporalis muscle, and it is an aging sign. So it is an area in which you can perform dermal filler. Obviously you have to pay attention to what? Venous and arterias. As you can see in this image, in here you can see that there are this bifurcation of the superficial temporary artery, and you have, what are the attention? Well, you have to perform this injection using a cannula, usually, and you have to inject slowly, really slowly, create small vectors, and in that kind of procedure we call it fanning. So you go inside with cannula, then inject in a retrograde way, then go inside again with a soft product. Why soft product? Because 50% of patients that has this kind of anesthetism has also thin skin. So obviously it could make sense to use more volumizing products, but if you have thin skin, patient will see the vectors. So it's better to choose a more softer product rather than a harder product, and make a great massage, and then maybe after 2 weeks perform again the procedure with another ml of product. But it is a nice area. Other areas, well, the infraorbital area is surely a dangerous area, because you have an artery, a vein, and a nerve from this point. But you have to remember 2 things about this place. First of all, you have a little piece of bone that cover the emergency of the artery. So it's really difficult to inject directly inside the infraorbital artery. Second, you have the nerve. So if you touch the nerve, the patient make a jump on your bed. So obviously it is a thing that it is useful for you as a practitioner, because you obviously you see the pain of your patient and you stop your injection. It is the reason because I don't like to make strong anesthesias in patients when I perform injections, because the pain of the patient is your friend. Obviously, if you perform a lip filler, you have to, because at that point the balance is between the pain of the patient and your difficulty to perform the injection in a good way, because it's really painful area. But in an area in which the patient can stay without anesthesia, please don't perform it. Because if you, for example, if you break a branch of the artery, the patient has a great pain, and so you can stop your injection, you can check the tissue. So in this way, don't perform blocking of the nerves if you have to perform injection of dermal fillers. Going down the other area, the oral area. You will heard about this artery that is called the facialis artery, and this area it's called nasolabial fold, and usually it is an area that we are going to fill with fillers, especially after we put some materials deeply on the bone in this area and zygomaticus arch. Why it's danger, this area? Well, because in the past this area were injected with the needle. So it was probably that you can inject directly inside the artery, and at this point we have a communication between facial artery, angular artery of the nose, and then this part that is an artery vessel linked with the internal carotid system. So, for example, you inject it in here, and with the flux of the blood, you can make some complications in other districts. Today, this area is injected with cannulas of 25 gauge, usually 25 or 22. So yes, it's a dangerous area, but with the adequate device, you can inject there without great complications. Okay, you will see tomorrow with my colleague the anatomy of the area, but you have to know that in this part, when the artery comes inside the face, the artery is deep, and coming laterally to medially, it becomes more superficial. So why here was dangerous? Because usually when you refine this area, you are superficial. But with cannulas, we can stay quiet and we don't have particular problems. Perioral region. Well, even when you perform a lip filler, you can have some problems. Surely lip is not the more dangerous area to inject, but as you can see, you have usually in the submucosal part of the lip, you have the inferior and superior labial artery that comes from the facial artery. How can you inject safer lip? Well, if you have a young patient, you can be more safer because you have thicker tissues. So usually when you perform a lip filler in a young woman, you say, okay, obviously with all the things that I told you before, so slow injection, small amount. Usually I perform injection with 0.1 ml for each injection on the lip. So not so much product for each injection. Then come outside, do a massage, and then check the tissue. You are pretty sure that you don't have a complication. You have to pay attention usually in this area, so the lateral part of the lip, because in this area the arteries are more superficial. So pay attention when you have to inject this part of the lip rather than the central part. In the central part you are safer. Obviously, as you told you before, if you use more invasive techniques, Russian lips, for example, in which you need a larger amount of products, in which you go inside many times with your needle from the same hole, and you go deeper in the tissue to have the inversion of this part, you are surely you have more risks. But why? Because when you go perpendicular and deep, probably you can cut the artery going up to down. For example, if you use, especially if you are a beginner, that so-called retrograde injection horizontally on the lip, you are safer because you find the plane and you inject slowly in the same plane. You don't go between more planes of the lip. Obviously, in my opinion, you can't use only horizontal technique when you inject a lip, because you are not able to reach the same degree of inversion without a vertical. So the technique is not the problem. The problem is pay attention of what you are doing. Vertical is a magnificent technique, but you have to choose it in a clever way. Don't inject vertically every lip. For example, if you have a 70-year-old woman with thin lips that are asking to you a volumization, think about, but how is her dental situation, how is her bony situation of the mouth, and after that you have the reabsorption of all tissue around the lip, not only the lip itself, and then you have really thin lips. So it's significant to imagine to use a vertical technique in an old woman. Probably not. Probably you can perform an injection with horizontal technique. You can give just a little bit of volumization and then focus maybe on perioral. There are a lot of patients that have that wrinkles around the lip, and probably it is the problem, not the volumization of the lip. So you can create combinations of treatments, obviously starting your decision from the needs of the patient, but think about all the district. Don't focus only on the lip. The problems usually came from this over-treatment. We choose a wrong technique for the wrong patient. Then we can have problems. If we think before, the patient is happy and you are happy too for the patient. In the slides I report also some images, and these images are about the evolution of complications. I report it because I want that you know that you have time, usually. For example, if you have an acute occlusion of a vessel of the nose, obviously you have to use immediately hyaluronic. But if you have compressions, for example for the lip, you have anastomosis of other vessels, so probably you have days to manage your complication. As you can see in there, you begin with the blanching, then you go to this that is so-called livedo reticularis, in which you see whitening areas and then red areas, and after that, for the anabolic metabolism of the area, then you have a changing in the color. In here there is a lack of oxygen, obviously, and in here you can have coagulation, bacterial infection, and in the end necrosis. But it needs time. So again, the point is the patient has to hold you, because you don't know what's happened outside your office. So leave to the patient an emergency number, or a number in which she can explain her problems. Well, I am an anxious doctor, maybe, so I give all to them my personal. They don't use if they don't need. Believe me, it's not a thing that every day 20 people call because of static medicine treatment. But they has to trust you, because if they are frightened by you, they don't call. And if you reach the stage 4 after 1 month because they are frightened by you, it is a problem for you. You need to know, and you need to know in here, probably, in livedo reticularis, not in this stage. And it's all about the communication. It's all about the patient trusts you and write to the doctor, what's happening in here? Please tell me what's happening. A lot of time people don't understand that maybe it's only edema. A lot of time happens that patient after 2 or 3 days has a labial edema, and I write to her, it's okay, it's all good. take maybe just a little bit of steroid or put some certain cream, it's okay. But you need to know. You need to know, because at this stage you can do really something. And at that time, for the patient, it's a great problem. So in here, I take a look about data in Turkey, and obviously the complication is associated to something: wrong techniques, poor muscle assessment. So a lot of these complications are linked to your lacking of time of studying your patient. Only this. You, at the end of this semester, you will have in your hands a lot of techniques, a lot of informations. You have to take your time, think adequately the situation of the patient, and then make the correct decision. You don't have to reach necrosis. For example, asymmetry. Asymmetry is a frequent complication, but you can fix it. Usually it happens with filler rather than botulinum toxin. In the beginning, it's normal to have some asymmetry. Every one of us did some asymmetry with botulinum toxin the first time we performed the treatment. It's normal, but you can correct it. So it's not a real problem. Infection, it's a problem, but it's linked to the sterility of the procedure. Usually we perceive these procedures as simple. You have to take off the cosmetics from the face of your patient, then you have to pass all disinfection before perform every treatment, from peeling to fillers to botulinum toxin, because the injection is obviously disruption of the barrier, so you can bring something deeper in the face of your patients. Prevention, well, sometimes are indicated the use of antibiotics. Well, it depends on the procedure. I don't give antibiotics before every procedure. Maybe only patients that has in their anamnesis some history of infection. Usually I give antiviral prescription in patients that has herpes labialis. That surely I give to them before, because if you perform an injection, you can trigger the herpes. So please give the medications. I want to tell you as last thing. I had, for example, a bell paralysis after an injection. I'm sure that I was lucky because I am an otolaryngologist and I treat bell paralysis, but in the beginning I was not so sure because the bell paralysis is progressive. I treated the cheek of the patient at that time with a hyaluronic acid filler, a normal procedure, really not difficult. The procedure were really okay. After 2 days, he refers this paralysis before in the lower part and then also the frontalis, and it makes me understand that in that case the filler was only the trigger, not the problem. You know that the bell paralysis, we really don't know the reason. Probably the cold or maybe a viral infection, don't know what. But surely, in my mind, the filler was the trigger of the pathology. But okay, but you have to know, you have to create this canal of communication with your patient, because the patient following the therapy of the bell paralysis will resolve it completely in 3 months. But if you speak with your patient, imagine this situation with a guy of the clinic of the colleague. You see the patient once, then what? The patient find his hemiface down, and then what's happening? What was the problem? In that case, aesthetics was not really the problem, it was a trigger. Maybe if the patient will go outside and take cold in his face, probably it will develop the pathology in the same way. We don't know, but you have to follow him. You have to follow him because really, this kind of complications could be a great problem for you, because if you have a complete paralysis of the face of your patient, imagine, wow, it was difficult, but if you take care of him, he follows you, he trusts you, and you can maybe call the otolaryngologist if you see this one, you can call your colleague that has another specialization to give you an advice. You have to take time and to take care of your patient. Okay, enough. We did our lesson for today, and I'll leave you the slides if you want to. And if you have questions, now it's time. Yeah.
The first one is there any article about your case?
No, I didn't publish, but I found in literature something about it. In the beginning, when well, I saw the patient 3 days after the procedure, because I performed the procedure on Thursday. It begins on Friday and it begins on Saturday. I was on the mountains at that time, so I saw him in Sunday. And he only has the oral region, so he have the falling of the angle of the lip. And after another day, he developed the problem of the orbit and then frontalis muscle. In that case, in the beginning, obviously, I think about filler, because you can have a compression. Maybe you develop an edema. The edema maybe can compress the nerve, and maybe you can have a little deficit. But if the filler was the problem, it was localized, obviously. I treated the cheek, you have the problem maybe of the marginalis. If you develop an entire paralysis, at that point, I realized that it was a bad paralysis. So I sent him to take a CT, an ictus, something vascular, why not? Then I give him the therapy. And then he began to do some neurorehabilitation like electrostimulation. We need 3 months for restitution interview, 3 months. But I asked to a friend that is my colleague, you will know him in some lessons, that is the colleague that works with me, and he told me that it was difficult to publish cases like this because you don't have a real connection. I can't prove this thing. And also, we are in a phase of literature that if you want to publish clinical cases, you have to pay. Because journals are more interested in systematic reviews or prospective studies rather than one patient case. So at that time we choose not to try to publish. But surely, in my opinion, it was tricky, and I was grateful of being an ENT, because probably if I were another specialist with that kind of experience with that pathology, I was really scared. Like, what I have to do now? Okay, but yes, it was interesting. Surely interesting after the restitution interview.
And the second question. Thank you, by the way. I want to learn the maximum time to apply Yolandas on a filler patient.
Well, ask me again.
For example, I apply the lip filler to a patient,
Okay.
and I want to apply Yolandas, but I want to learn the maximum time that I can apply. I mean, 2 weeks later, 2 months later, or like, can I apply it off, for
Okay.
example, 6 months later?
Well, you have to think about 3 elements. If you want to add some filler in order to complete the treatment, you can wait 2 weeks maybe, because you have to wait that all the edema or the echinosis are completely solved. After 6 months, probably it's another treatment, because in a large part of cases you obviously have a resorption of the product.
Okay. For example, I performed a lip filler to a patient and it had some bumps.
Yes.
And for these bumps, for example, the patient comes to me like 2 months later, can I apply hyaluronidas as this bump?
Yes, surely you have to do it. Sure. The only way to solve the bump is to use
And
hyaluronidas.
there's no time limit, right?
No. Well, if you use hyaluronidas, surely you can have a lot of problems, because in here you have supracochlear and supraorbitary arteries, and they come from deep to the superficial, and you have to pay a lot of attention if you put your needle in this area and you go inside the subcutis and the muscle. So pay a great attention if you choose to inject it. But usually I don't perform it, because botulinum toxin is more than sufficient to make happy the patient. Another thing, again, if you see a patient that has deep frontal wrinkles in the frontalis muscle, ask yourself why. Why this person has so deep wrinkles in the frontalis? Well, the answer, when you think about a patient of middle age, is that probably the patient uses the frontalis muscle to sustain the upper part of the eye. Because if you have a lot of cutis in this, maybe with this activity of frontalis muscle, the patient make open their eye. So think why it has so deep wrinkles